Hello, everyone, and welcome to our module on the lung physical exam. So in this video, we're going to talk about the different ways that we perform the physical exam on the lungs. So some of these are shown in this slide. Auscultation is one of the main ways we examine the lungs. That involves placing the stethoscope on the thorax, like shown here, and listening to air movement through the lungs. We'll talk about percussion, which involves putting a finger against the thorax and tapping with your finger. And then we'll talk about some special techniques like Fremides and pectoriliquy. Before I go any further, let me define a term that you may or may not be familiar with, and that is lung consolidation. So consolidation in the lungs means the alveoli have become filled with either fluid, cells, or blood, or a combination of these things. The classic cause of lung consolidation is pneumonia. So this is an example on the slide here of a chest x-ray from a person with a right upper lobe pneumonia. And that can also be referred to as a right upper lobe consolidation. You can also have consolidation from other types of fluid or cells or blood in the lung fields, things like pulmonary edema and hemorrhage. But as I said, the classic cause is lobar pneumonia. And so in this video, some of the physical exam findings we'll talk about are seen in consolidation. And now you know what I mean when I say that. Okay, let's start by talking about auscultation of the lungs. So auscultation involves placing the stethoscope usually on the patient's back, although sometimes in the front as well, and listening as air moves in and out of the lungs. And the normal breath sounds that you hear as air moves in and out of healthy lungs are called vesicular lung sounds. They get this name because the alveoli used to be called historically the vesicles of the lungs, and so normal breath sounds filling the alveoli were described as vesicular. And in terms of pathologic lung processes, most pathologic lung disease leads to either decreased lung sounds over the affected area or completely absent lung sounds over the affected area. On this slide is a diagram from a textbook showing you some different pathologic lung conditions like emphysema and pleural effusion, and it describes some of the findings you'll see, including other findings we'll talk about later. But you can see that for breath sounds here, for almost every process that's shown here, it lists either V for diminished sounds or O for absent sounds. And so now I'm going to play you an example of what vesicular lungs sound like. They may give you examples of actual lung sounds on your board exams. I will tell you that it's very hard to distinguish normal and pathologic lung sounds. It's very unlikely they'll expect you to be able to do this without a lot of hints from the question. So usually the question will give you lots of hints at the diagnosis, and listening to the lung sounds is just supportive of those findings. And so here's an example of vesicular lung sounds. Okay, now let's talk about percussion of the lungs. So percussion involves placing a finger against the patient's back and tapping along the different lung fields and listening to the sound that comes back from your finger tapping against the thorax. And normal sounds that you hear from a patient who has healthy lungs are described as resonant. Abnormal findings due to percussion are either dull or hyper-resonant percussion sounds. So dull sounds sound like you're tapping against a fluid-filled space, like you're tapping against a bottle that's filled with liquid, for example. These are the findings that you get in pleural effusion. You can also see this in consolidation, like from pneumonia. Hyperresonant sounds sound like you're tapping against a drum, an area of the lungs filled with extra air compared to usual. That's why they're called hyperresonant. So this is what happens when there's air trapped in a portion of the lungs. So you can see this in pneumothorax. You can also see it in emphysema, where patients have air trapping. Now let's talk about adventitious lung sounds, which is the term that's used to describe extra or non-native lung sounds. In other words, lung sounds that are pathologic and aren't heard in normal lungs. These are all sounds you hear with the stethoscope, like what's shown here. And we'll go through all of these right here in the next few slides. So rales are also called crackles. This is a sound that occurs when the small airways pop open after they have collapsed for some reason. You can further describe rales as whether they occur early during inspiration, late during inspiration, or during expiration. And sometimes rales can be heard through all three of these phases of the respiratory cycle, sometimes just one. Some of the classic causes are shown here. So the big one is pulmonary edema. So this is an x-ray of pulmonary edema here. And when there's fluid in the lungs, for example, from heart failure, gravity will draw that fluid down towards the bases of the lungs, and you will hear rales or crackles at the lung bases. You can also hear rales in pneumonia. Classically, the rales are late inspiratory, and you can also hear rales throughout all of the lung fields in patients who have interstitial fibrosis. And now I'll play you an example of what rails sound like. Keep your ears open for that crackling sound. Okay, wheezes are a sound that air makes when it flows through a narrowed bronchi. Usually wheezes are expiratory, but sometimes they can be both inspiratory and expiratory throughout the respiratory cycle. The classic cause of wheezes is asthma. In patients having an asthma exacerbation, they will have wheezes throughout all the lung fields. You can also sometimes get wheezes from pulmonary edema in heart failure. This is called cardiac asthma. Basically, the pulmonary edema narrows some of the bronchi. You can hear wheezes in chronic bronchitis from inflammation and narrowing of the bronchi. And then you can also get wheezes anytime there's an obstruction. So, for example, if there's a tumor that's obstructing airflow through one major bronchi or a branch, that can lead to a localized wheeze as a finding. And so now I'll play you an example of what wheezes sound like. Okay, let's talk about rhonchi. So rhonchi are caused by secretions in large airways. Rhonchi are often described as coarse breath sounds, and what this term means is breath sounds that are low-pitched and louder, and they sort of sound like turbulent flow, like the air is not flowing smoothly through the bronchi. That's what rhonchi sound like, and that's why they're called coarse breath sounds. The classic cause of rhonchi is COPD, although you can also hear them in patients with respiratory infections if they have mucus clogging up the large airways. And now I'll play an example of what rhonchi sound like. Let's talk about bronchial breath sounds. So bronchial breath sounds are high-pitched lung sounds. They sound like air flowing through a tube. Usually they're associated with a longer expiratory phase than normal. And bronchial breath sounds are a classic sign of pneumonia with consolidation. And so now I'll play you an example of what bronchial sounds sound like. Stridor is a special type of wheeze that's almost entirely inspiratory, and it's heard loudest over the neck. It's caused by partial obstruction of higher portions of the airway, places like the larynx or the trachea, not the small airways deep in the lungs. There are a number of causes of stridor. I've listed some of the classic ones right here. Children who develop croup can have laryngotracheitis and they can develop stridor. This is a very serious finding because it means that there's inflammation that could cut off the airway. Children who aren't vaccinated against H. influenza B can develop epiglottitis, and that can lead to stridor. You can also see it in retropharyngeal abscess and diphtheria. And if you look at these images on the slide, at the bottom is a swollen, enlarged epiglottis. I don't think they're going to ask you to recognize this on your board exams by X-ray alone. But when you develop swelling of the epiglottis like this, that can lead to stridor. And then in the top right here, I've got a picture of someone who has a retropharyngeal abscess, this dark space sort of beneath the chin there. That also can cause stridor by partially obstructing the larynx or trachea. Okay, now let's talk about some special findings on the lung physical exam, and the first one we'll talk about is pectoriloquy. So this term literally means that you can hear the patient's voice with the stethoscope placed on the back of the chest. It means you hear voice sounds through the stethoscope when you're listening to the back of the chest. There are a couple of subtypes of pectoriloquy. One is bronchophony. This means you can hear voice sounds through the stethoscope, but they are louder and clearer compared to normal. Another type of pectoriloquy is whispered pectoriloquy. For this finding, you ask the patient to whisper 99, 99, 99 over and over again. You should hear this through the stethoscope, but it should be muffled. But it's abnormal if you can hear them saying 99 clearly. Another type of pectoriloquy is agophony. For this finding, you ask the patient to say E, and it comes through your stethoscope sounding like A. And so all of these subtypes of pectoriloquy indicate fluid in the lungs, and they are all classic findings in lobar pneumonia. Really, these are sort of historical things. Years ago, before we had chest x-rays, doctors had to use their stethoscope a lot to make complex diagnoses of lung disease. Lobar consolidation from pneumonia was very common, and so abnormal findings of pectoriloquy were one of the ways that doctors would diagnose lobar pneumonia. Fremitus is a physical exam finding that you can appreciate by placing your hands on the patient's chest, either on the front of the chest like what's shown here, or on the side or on the back of the chest. And then you ask the patient to say 99. And when they do this, vibrations will travel through the airways to the chest wall, and you can feel those along the palms of your hand. And the amount of vibration that you feel varies with the density of lung tissue. And so the main thing to know about Fremitus, one of the most important things to remember, is that it is increased in lobar pneumonia. And this is really the only important pulmonary condition with increased Fremitus, where you feel more vibrations compared to what is normal. Most other pulmonary processes lead to decreased Fremitus. So things like pleural effusions, pneumothorax, atelectasis, all these things will lead to decreased Fremitus, which is a finding that has many more causes compared to increased Fremitus like you see in lobar pneumonia. And then the last thing I'll talk about is tracheal deviation. So there are certain pathologic lung processes that can cause the trachea to deviate away from its normal midline position so that it shifts to the left or to the right. And you can assess this by inspecting the patient's neck, by palpating the trachea, but more often in the modern era, we assess the trachea for deviation on imaging. So a simple chest x-ray usually lets you see the trachea very well, and you can tell if it's deviated to the left or right. The normal position is midline, but there are certain pathologic lung conditions that cause the trachea to deviate towards the affected side. In other words, toward the side with the pathologic process. So if you have a lobe collapse and you have atelectasis, the trachea will deviate towards that side. You can also see this happen if there's a mucus plug and there's no airflow to a lobe or a major section of the lung. This can also cause tracheal deviation toward the side with the abnormality. And then there are a couple of other conditions that cause deviation away from the side with the abnormality. So if you have a very large pleural effusion, all that fluid can push the trachea away from the side with the pleural effusion. Same thing can happen in a pneumothorax. If you have a large pneumothorax, especially a tension pneumothorax, the pressure buildup in the side of the lung, which has the hole, can push the trachea away from that side. So on this slide, I've placed a summary table of all the different lung exam findings in different conditions. So remember, breath sounds are decreased over the affected area in almost all lung conditions. Percussion is dull when you have a pleural effusion on one side or atelectasis on one side. And then percussion becomes hyperresonant when there's trapped air from a pneumothorax. Fremitus is decreased in all the lung conditions on this table. The only condition where Fremitus is increased is lobar pneumonia, and I'll talk about that in a second. And then right here, I've summarized the important examples of when the trachea becomes deviated. The only time it's really deviated towards the affected side is in atelectasis. Pleural effusions, tension pneumothorax, these cause the trachea to deviate away from the lesion. And so remember what I said before, that the diagnosis of lobar pneumonia used to be something that physicians had to do commonly with just the stethoscope and their physical exam skills. And lobar pneumonia was very common. It was termed lung consolidation. And so it had a whole set of classic abnormal findings, and they're all summarized here. So when you have consolidation, like for example, this patient here who has a right upper lobe pneumonia, percussion will be dull. Fremitus will be increased, and this is unusual. Fremitus usually decreases in pathologic conditions. And then you can have all these breath sound abnormalities I've described here. And one other comment, even though I showed you examples of what some of these breath sound abnormalities sound like, they are very hard to recognize just with your ear without any context. So when you see these in board exam questions, they are almost always going to give you lots of clues about what the lung condition is, and you're not going to have to diagnose it solely by the lung sounds. That is very, very hard to do. And the last thing I'll finish with in this video is nail clubbing. So this is a picture of what nail clubbing looks like here. You can see that the fingernails have become protruded and rounded out and curved like this. And this is a finding that occurs in association with many pulmonary diseases for reasons that are poorly understood. We really don't understand the pathophysiology of nail clubbing, but you can definitely see it in things like bronchiectasis, in cystic fibrosis patients, patients with lung tumors, and patients with pulmonary fibrosis. It's also a classic finding in children who have cyanotic congenital heart disease like tetralogy of Fallot. Once again, we don't really know why this happens, but you should be familiar with this finding, and these are some pictures of it on the slide here so you can get an idea of what it looks like. And that concludes our module on the lung physical exam.